I'm going to talk today about endocrine emergencies that you might see in intensive care. Hopefully you can hear me all right. If not, give me a wave and a shout. I'm Jenny Briggs, for those of you who I've not met. I'm based at the Leicester Royal and I'm one of the intensive care and anaesthetic consultants. I don't profess to have any particular expertise in endocrinology, but hopefully we can have a bash through this together and hopefully all learn a bit and have a discussion of any interesting cases. Okay, so what I am going to talk about is a little bit about thyroid physiology and some acute thyroid presentations that you may see. A bit about calcium and the adrenal axis and stress response, which is really important in intensive care. A bit about adrenal disorders, and also a bit of a discussion about steroids and some of the evidence base behind that, which has changed a bit recently as well. Also a little bit about potassium. It is very unusual to get endocrine emergencies that aren't diabetes, and most of the time, if you think you've got one, it's probably something else much more boring instead. However, occasionally they do pop up or they may complicate other presentations, so it is worth knowing about them. Having said all of that, I have personally admitted somebody with malignant hypercalcemia and somebody with diabetes insipidus with a very high sodium in the last few years, so anything is possible. What I'm not going to talk about though is DKA or HONC or whatever we want to call it these days, nor the perioperative management of diabetes, pumps, that kind of stuff. I'm also not going to talk about sodium, and so we'll touch on potassium a little bit if we have time, but we're not going to spend a lot of time focusing on that really. So, thyroid physiology. So going back to your sort of medical school days, have we got any medical students on the unit at the minute? No, okay. So you remember that the thyroid physiology, a lot of it is T4 with a small portion of T3, and T4 is actually the less potent version. Thyroid is really essential really for most organ systems to function normally, and for homeostasis. Most of the thyroid hormones in the body, T3 and T4, are carried in the blood bound to proteins. The vast majority of thyroglobulin binding thyroid binding globulin, quite a lot to albumin, and then a bit to this other protein called transthyretin as well. A very small fraction of T3 and T4 is unbound. We're talking about less than 0.3%, and the majority of that is T4 rather than T3, although T3 is the most active part. You'll remember that iodine is important in thyroid physiology. Iodine reacts with tyrosine to make T3 and T4, and then T4 is converted within the tissues and the liver and kidneys to form T3, which is the more active form. Now, quite a few things can influence the speed at which that conversion occurs. Things like stress, starvation, some drugs, including things like amiodarone, which we use quite a lot in intensive care, and they have unintended consequences for thyroid physiology. And you remember that the hypothalamus releases thyroid releasing hormone, which then acts on the pituitary and produces TSH, which acts on the thyroid to release T3 and T4, and makes a feedback loop to ensure that that is kept in a steady state. So, hypothyroidism then, signs and symptoms. Anybody want to shout any out?
Weight gain, constipation, lethargy.
Yeah. So try and make sure that you categorize your answers when you can. Any more? So I think the pictures are quite useful. So it's sort of like a sleepy state really, isn't it? So hair loss, apathy, lethargy, dry skin, everything kind of slows down a bit. So constipation, cold intolerance, loss of hair, can get facial edema, sort of a dull mask-like expression, fatigue, and things like slow speech and brittle hair nails, and also menstrual and sexual dysfunction as well. Might also present with things like bradycardia, hypothermia, weight gain, and cardiac complications too. So hyperthyroidism is kind of the opposite, really. It's sort of a go faster state, isn't it, really? So muscle wasting because it's used up, and weight loss, diarrhea, again, menstrual changes, tremors, and again, hair and eye changes, facial changes. It can be quite characteristic. Can also get localized edema as well. There are a few extreme versions of thyroid pathologies that they may present in crisis to us. So extremes of hypothyroidism or hyperthyroidism, one of which is thyroid storm, which is extreme hyperthyroidism. This can be a life-threatening emergency, and it's got a very high mortality rate. And it can be quite difficult to pick up because of the way it can present in a whole variety of different sort of vague symptoms. Often it's precipitated by something else like intercurrent infection or surgery. So it happens because of any one of the sort of controlled parts of the system going awry. So maybe because you get increased T3 and T4, maybe because you get a reduction in the proteins that normally bind the thyroxine within the blood, maybe sensitivity to the T3 and T4 changes, some change in the sort of regulatory set point that occurs, and that can occur in critical illness, or maybe because of intense sympathetic stimulation, which can upregulate your receptors. So what can precipitate it? Any ideas? So a lot of the things that might end up with patients landing up with us, really. So sepsis, surgery and trauma, pregnancy, and particularly labour, DKA, seizures and CVAs, PEs, burns, stress states. Also things like excessive palpation. So you know, if somebody's got a really lovely goiter, everybody wants to have a feel. That might land somebody up in crisis. But also some iatrogenic things as well, things like radioactive iodine therapy, radio contrast, those kinds of things. So we do need to be a little bit mindful if we've got patients with significant thyroid pathology when we're perhaps ordering some of those tests and treatments. Okay, so we'll organise our sort of signs and symptoms by system. So a whole variety of things that can occur. Can present if you've got a very large goiter with signs of sort of respiratory compression, airway compression, but also with things like tachypnea, pulmonary edema, because of the high sort of metabolic state, very high levels of CO2 production, which may result in respiratory failure. Also significant cardiovascular symptoms, including things like hypotension, shock, vascular collapse. There's a high output state, so they may also end up with sort of heart failure type symptoms too. Rhabdomyolysis may mean that, you know, that can be a rare cause of rhabdomyolysis and renal failure, and some of the other sort of endocrine abnormalities may be caused by extreme hyperthyroidism as well. So it's something that's very unusual, but if you don't suspect it, you definitely won't pick it up. So how do we manage it? So again, with most things, it's supportive. So fluids, making sure that we're being mindful of this very high output cardiac state and not resulting in fluid overload of the patient. Remembering that because it is a very high sort of catabolic state, that things like thiamine may be in short supply, and there may be nutritional failure as well. So making sure we're supplementing those aspects of the patients whilst we're sorting out a thyroid disease. Often there is a precipitant, so making sure that we've looked for that, making sure that if there is any sepsis, we've identified it and treated it. Often they do get a lot of adrenergic symptoms, and that may require treatments to control those and prevent any further complications, including things like beta blockers, particularly propranolol. In addition to controlling heart rate, it also reduces the peripheral conversion of T4 to T3, which can be very useful. You might need to give beta blockers enterally or IV. Electrolyte disturbances are common, so you do need to correct those as well. Once you've controlled the electrolytes, then you may need to try and control heart rate with digoxin. Because of the fact we've said amiodarone affects the thyroid conversion of T3 to T4, it's best to avoid amiodarone in these patients if you can. And then propylthiouracil, which again blocks the conversion of T4 to T3, and that can be given orally or rectally. Because the adrenal may become exhausted because of the very high metabolic rate, some of these patients may exhibit adrenal failure as well. So steroids can actually be useful. And in addition, quite a few of the patients will have an autoimmune pathology causing their disease. So steroids can be helpful for that reason too. If it's severe, they may need things like plasmapheresis or dantrolene, particularly if they've got significant muscle involvement, just to try and sort of turn off the sort of process behind it. Yeah, and just be cautious if you've got retrosternal goiters or airway compromise, and that may get worse if they become obtunded. So we mentioned cardiac failure. So you do get sort of functional and sort of structural changes in the cardiovascular system, both peripherally and within the myocardium. They do get an increase in total body volume and also an increase in preload, as well as a reduction in afterload as well, and also a high heart rate, as well as increased contractility. So all of these things together mean that they're quite high risk of high output cardiac failure. And sometimes as you fluid resuscitate and then control things like heart rate, they may actually decompensate that at that point. So heart failure can be quite common, particularly with older patients. There is a question as to the reversibility of the cardiomyopathy. Some people say it does improve once you actually control the overall problem. So opposite of that then is mixed edematous crisis. It's extremely rare, but has a very high mortality rate. And it's a bit of a misnomer really, because most of them are not in a coma and mostly they don't have mixed edema either. However, it's worth considering if you get a patient presenting with reduced GCS who is cold, often an older lady, and it may well be that they've had undiagnosed or long-standing hypothyroidism for many years that's just not been picked up. Often they'll sort of be bumbling along this hypothyroid state and then something else happens that pushes them over the edge. So precipitants, again, all the things we've talked about before really, anything that adds extra stress into the system, so infections, stroke, surgery, trauma, but also, again, drugs. Amiodarone seems to be a frequent offender in these. Things like lithium too, so patients with bipolar disorder, and some drugs used to treat things like TB as well. So if you have an altered mental status with hypothermia and clinical features worth considering, and what lab findings might you expect? So you're going to see low T3 and T4, but it might also be worth measuring TSH, and that will help you figure out whether it's secondary to something else, or if it's a primary thyroid problem. But don't forget that your other electrolytes will get deranged as well. So things like sodium balance will be abnormal, phosphate, and also glucose control can be problematic. Often patients may be in AKI, and they may exhibit a respiratory acidosis with hypoxia and hypercarbia as well. Because they present with an altered mental status, they may end up having a lumbar puncture, and if you do that, they'll have a high opening pressure and an elevated protein on analysis. So clinical features, busy slide, sorry. So we talked about reduced GCS, may also present with psychological or psychiatric symptoms too, and occasionally we do get patients admitted from psychiatric units when they've deteriorated, and then it becomes clear there's a medical cause, so worth considering in those patients. Things like slow relaxing reflexes, fatigue, and weakness, cardiovascular symptoms, including some ECG changes, muscle weakness, particularly respiratory muscles, pleural effusion, so a whole variety of weird and wonderful sort of vague symptoms. Macroglossia, which again complicates airway matters if they've got vocal cord edema and goiters, and maybe voice changes too. So a whole variety of things. So how do we manage it? Again, largely supportive, rewarming the patient, replacing steroids, and then thinking about replacing thyroid hormones as well. Now you can use an IV preparation of this, which I think is called liothyronine. It's very expensive, and it's actually got quite a lot more complications associated with it. And actually the oral bioavailability of thyroxine is pretty good. So most of the time you don't need to use an IV preparation at all. And our pharmacy colleagues, will remind us that actually enteral thyroxine replacement is usually more than adequate for these patients, even in very severe states. If they do require an IV preparation, it's usually only one-off, and then a switch back to enteral as soon as you can. Rapid replacement, rapid correction can cause decompensation too. So although we may have worries about GI stasis, actually it might be better to go a little bit more slowly. I think the difficult thing with a lot of the endocrine pathologies in ICU is that actually a lot of the tests that you would normally measure, and for our medical colleagues, medical trainees amongst us, you'll notice that we often don't measure things that you might think would be a good idea to measure, and it's because a lot of them are deranged as part of critical illness anyway, and that makes it very difficult to interpret. So you might have heard of euthyroid 6 syndrome, and this is kind of like an alteration of the sort of set point and the normal sort of control, what's the word I'm looking for, homeostasis. The homeostatic set point is set, it changes either to be a higher set point or a lower set point. So there are two types. Type 1, which is like a hibernational state, seen in hibernating animals and fetal state, where the body kind of goes into a sort of conservation type mode where it tries to conserve its resources, and everything is sort of down regulated to conserve what's left. This is very commonly seen in critical illness. The opposite of this is type 2, which is often seen in things like pregnancy, and actually the sort of set point is reset to a higher level, so sort of increased metabolic rate, and we see a lot of sort of down regulation of T3, T4 in critically ill patients in line with this. Okay, so moving on now, calcium. So calcium is really quite important in the body. Does a whole variety of things. Very important in electrically active tissues throughout the body, so smooth muscle, cardiac muscle, as well as skeletal muscle. A lot of the neurotransmitters rely on calcium release to maintain normal function. Really important in our blood clotting cascade, and if you have a massive hemorrhage, it's really important that we replace it. And also really important for things like hormone release, ciliary function, and growth, as well as bone function too. We have a large amount of calcium in the body. The vast majority of it is stored in bones. Only a very small amount of it is in the extracellular fluid, 0.1% of our total body calcium, and that's the bit that's sort of electrically active and important, really. Small amount of it is intracellular as well. So again, controlled by the thyroid and the parathyroid glands, the kidneys very much involved as well, and the main hormones are things like calcitonin, and your body picks up that you've got a low calcium state, and you've got rising blood calcium level, calcitonin release increases, and then you get reduced uptake and increased secretion of calcium from the kidneys, and you get deposition of calcium into bones, and your osteoclasts down regulate as well, and that drops your calcium level back down again. Opposite happens if your calcium level falls. Parathyroid glands detect that and release parathyroid hormone, so you get increased osteoclast activity in the bones and increased calcium uptake within the bowel and within the kidney to return things to a more normal state. So it can vary quite a lot in terms of the concentration, depending on the serum proteins, particularly things like albumin, also with pH, and to some extent phosphate and magnesium levels as well. So if your patient's got severe hypoalbuminemia or very acidotic or alkalotic, then you need to adjust for these to be able to make an accurate assessment of the state of calcium in that patient. And this is where the adjusted calcium that we measure comes from. Remembering that it's only the ionised portion of calcium that's active. So actually, if you don't correct for these, you might think that the ionised calcium's fine, and it's really not. So, signs and symptoms of hypercalcemia. So this is bones, stones, groans, and psychic moans. And certainly the patient that I was involved with some years ago now had all of these things. It's quite a sad story. He was a Gurkha over from Nepal, serving the British Army, and he'd left the forces and had become quite depressed. He'd been really struggling with his diet. He'd been having lots of renal problems and renal stones, feeling quite nauseated, not really eating, and getting weaker and weaker. And because of his psychiatric symptoms, had become homeless, and was being supported by a charity, and presented to us with severe ARDS, and unfortunately died. That case was written up, but it was a very, looking back, it was a perfect example of the symptoms that these patients can exhibit. So by definition, it is a total serum calcium more than 3. And if it's more than 3.5, it's counted as severe. I can't remember what his was, but it was, I think, around 5 or 6. It was something bonkers. They get a whole variety of weird and wonderful symptoms. And as with most things, management is largely supportive, but there are some specific things. These patients are often very dehydrated and need quite significant rehydration with saline. And then a furosemide diuresis to try and improve calcium removal from the body. IV permethrinate can also be useful too, particularly if there is a malignant process affecting bones. But in any patient with hypercalcemia, permethrinate may be very beneficial. So causes, like I said, can often be a complication of malignancy with bony mets. Can be related to sort of a rebound where patients have been in a hypocalcemic state. We may see a rebound from that. Maybe be related to parathyroid disease in all its varieties and forms. May also be related to things like prolonged immobilization and changes in volume state, as well as iatrogenic calcium administration. So all of these things you may see in ICU patients. Can anybody think of any particular therapy that we use that may have a big impact on calcium metabolism within the body? Something we use to support other organs. So because we now use citrate to anticoagulate our CVBH circuits rather than heparin, this can quite significantly affect calcium levels. So the nurses add citrate to the extracorporeal circuit, and then they replace the calcium, and they're measuring the calcium within the patient to allow them to titrate the calcium replacement as well. So it's really important that calcium and citrate are balanced, and the citrate doesn't accumulates, because that can make things quite significantly worse. Things like TPN and complex refeeding as well can also be problematic occasionally. Less common causes, things like myeloma, thyrotoxicosis, we said that can do all sorts of weird things. Lithium can cause all sorts of endocrine mayhem. Rarely things like growth hormone and metprozole, theophylline, but clinically that doesn't seem to be particularly a problem. And some of the granulomatous diseases as well, things like sarcoid and TB. Okay, so hypocalcemia, again, this may actually be true or sort of apparent in the way we're measuring it. Can be related to low albumin states and severe alkalosis, as well as things like rhabdo and renal failure and tumour lysis syndrome. So maybe a particular relevance in some of our haematology oncology patients, particularly when they first come to us with a very large tumour burden. And they've just started on the chemo or steroids. We do need to be mindful of their calcium levels, partly so that we can monitor and replace it, but also because it may be a sign of tumour lysis occurring. So when should we correct it? So there are some absolute and relative indications to correct it. Correcting electrolytes is always a slightly difficult thing to suggest in your plan on a ward round, particularly if Dr. Scott is on duty. So always worth knowing what the absolute and relative indications are. So absolute, if the patient's symptomatic, if their ionised calcium is extremely low, so less than 0.8, hyperkalemia, and if they've got calcium channel blocker overdosage. Other things, if they've got very high nitrate requirements, calcium replacement may be beneficial. Things like massive blood transfusion, we always try and replace calcium. And if magnesium is very deranged, so think about obstetric patients, or if somebody's given a bit too much magnesium for some reason, those patients may benefit from it as well. Might improve sort of respiratory muscle function and things. Okay, so ionised hypocalcemia, that's really small, isn't it? Sorry. So we talked about calcium chelation, which things like citrate, things like alkalosis, tumor-lysis syndrome. I think we've covered most of that really, haven't we? Sometimes if they're taking the thyroid gland out, they may actually accidentally take all the parathyroids out too. And so if patients have had total thyroidectomy, sometimes we'll monitor the calcium levels afterwards as well, and make sure that they do still have the ability to sort out their own calcium levels and may require supplementation for the first few days. Often the parathyroids get a bit bruised. Fine. All right, so moving on. So stress response is something that we see a lot of in ICU and that we manipulate quite a bit as well. You'll remember that any stress leads to increased activity in the hypothalamus with corticotrophin releasing hormone acting on your pituitary via ACTH, then acting on your adrenal glands to increase cortisol production, and another beautiful feedback loop. So stress response occurs in response to any kind of trauma, whether that's premeditated trauma by a surgeon or some kind of accident, hypovolemia and pain. You get a neuroendocrine response with increased cortisol, which you remember breaks down muscle and lipids, leads to hypoglycemia and has some anti-inflammatory properties. You get endorphin and prolactin release. Growth hormone gets released too to try and improve muscle repair and tissue damage. You get ADH release, so you get water and sodium retention with opposite potassium loss. And this is sometimes how we know that the patient is getting better, is that they have big diuresis and start losing that excess water and sodium that they've been retaining. You get increased sympathetic stimulation, so catecholamines go up, your renin goes up, so you get angiotensin 2 and aldosterone increase. You get high catabolism and cytokine production, particularly things like acute phase reactants and lymphocytes and leukocytes. And you get a reduction in things like your anabolic hormones, which is why patients who are in intensive care who are not diabetic often have an insulin requirement to maintain normal glycemia during this time. Stress response can be suppressed by high-dose opioids, also by things like spinal or neuroaxial blockades prior to the insult. And the sort of traditional teaching was if you've got patients that were unlikely to cope well with stress response, then intrathecal techniques and epidurals helped them cope with that sort of stress response to surgery. Etomidate was a very wonderful induction agent, beautifully cardiac stable, but unfortunately completely nobbles your adrenal glands even after one dose, and often used in patients who are particularly unstable and sick, which are exactly the patients that really need their adrenal glands to do the fair thing to try and get them better. So that's why we stopped using it. So adrenal insufficiency can vary in severity. Some patients may have Addison's disease, which is a chronic condition, but if something else happens to them, then they may be pushed over into a crisis, which is a medical emergency, often caused by an intercurrent illness, forgetting to take medication or some kind of surgical insult. It's important that we think about sort of adrenal insufficiency, and some patients who are critically ill may have sort of an intercurrent adrenal insufficiency, just because sort of demand is outstripping supply in their disease state. So causes, again, whole variety of things, often maybe autoimmune, sometimes maybe gland destruction either by tumour or TB or surgery. Patients with sepsis, particularly things like meningococcal sepsis, can occasionally hemorrhage into their adrenal glands and destroy them, which can be a problem. They might get infiltrated by things like amyloid as well as tumours, and certain drugs can nobble them too. We mentioned etomidate, but things like fluconazole, rifampicin, phenytoin. Often secondary to sort of stopping exogenous steroids, remembering that some patients may be taking steroids illicitly, either for body building reasons, or a whole variety of reasons. So sometimes patients may not disclose their steroid use. Things like steroid creams at high levels, high dose inhalers can sometimes have enough systemic absorption to cause a problem if they're stopped suddenly. But anybody taking more than 30 milligrams per day of hydrocortisone, which is about 7.5 of prednisolone, is at risk if they've been on that for more than 3 weeks. You may also, as we said, get this relative adrenal insufficiency in critical illness states, and various disease processes in critical illness have had steroids suggested as a treatment modality in the past, with greater or lesser success. So what are the symptoms of Addison's disease? So again, a lot of them quite vague. Sort of particular things to notice is things like hyperpigmentation of skin creases of the buccal mucosa, vitiligo, and changes to skin and hair distribution. And then we have postural hypertension. They may be quite vasodilated and shocked, and they may have potassium and salt abnormalities as well. Might have things like diarrhea, which of course worsens everything as well. Mood changes, headaches, sweating. And the treatment is both glucocorticoid, but also remembering to replace the mineralocorticoid. And sometimes we forget about that aspect of treating these patients. So it's really important to give fluticasone as well for these patients. So yeah, that's just a picture to summarise it. Often things like profound fatigue. We talked about sodium being low, and changes in potassium as well. Okay, so Addisonian crisis. If patients have Addisonian crisis, they'll often present in shock. That shock may well be resistant and refractory to fluid and to vasopressor resuscitation. Occasionally they might have abdominal pain, so they might come in as an acute abdomen, and they often have hyperkalemia and hyponatremia as well. Sometimes also hypoglycemic. Again, sodium chloride is quite useful for these patients. Supportive treatment and making sure we replace their steroids, and then looking for a cause, which often is something like sepsis or trauma. So everybody likes to think about FEO. It's a 10% tumour. It is rare, but we do see it, and Dr. McLaren has particular experience and expertise in looking after these patients. So he's the man to talk to if you want to learn more about perioperative care of these patients. Signs and symptoms often, again, quite vague. Things like hypertension, which may be precipitated by poking the tumour. Surgery, general anaesthesia and beta blockers can also make it worse. Might be sweaty, palpitations, headaches, changes in blood pressure or heart failure. The treatment so often needs to be carefully planned. It's really important that the patient gets beta blocker after the alpha blocker has been started. So sometimes these patients may have changes in blood pressure, might get put on a beta blocker, and then everything just gets much worse because they've got unopposed alpha activity. So start their alpha blocker first, not the beta blocker, and then largely supportive care. So moving on to steroids now. I think it's fair to say the role and usage of steroids has changed quite a bit in the last 50 years. There are some conditions where there is good evidence of benefit, some where there's good evidence of harm, and some where practice varies and evidence is conflicting. So there is a proven role for steroid treatment in things like vasculitis, myasthenic and mixed emesis crises, in organ transplant, both in the donor and in the recipient, things like thyroid storm, hypercalcemia, but also in patients with pneumocystis pneumonia, where it can be very, very helpful. Also, obviously, things like Addisonian crisis, anaphylaxis, asthma, in bacterial meningitis, and preferably before the antibiotics. And it improves penetration of the antibiotics to the cell and reduces neurological disability and mortality in these patients. Obviously, in patients with COPD, things like creep, and as we all know, very useful in patients with COVID who have an oxygen requirement. Areas of debate. So ARDS. So the ARDSNet paper suggested that steroids were useful in patients with ARDS to improve weaning, oxygenation and compliance, but didn't show any overall mortality benefit. There's been several meta-analyses since then showing improvement and maybe a trend towards reducing mortality. If you start them late, though, they may increase mortality and may worsen outcome. So I think it's fair to say, there's still some further work needed in this area. Thinking about the underlying cause as well, if it's something that's likely to be steroid responsive, then it may be more helpful. Transfusion-related lung injury, again, was thought to be useful. Some evidence of benefit previously, but not currently recommended. Pneumonia, so the evidence based on this has changed recently. There have been conflicting studies previously, and NICE and UpToDate were not previously recommending steroids, but the ESCAPE study and the Cape Cod studies have reported in the last couple of years showing benefit of steroids, particularly for patients with severe community-acquired pneumonia in terms of mortality and morbidity. So I think there is now a sort of increasing push towards giving steroids for community-acquired pneumonia patients who are requiring critical care. Worth considering in patients where PJP may be a possibility, particularly patients who are immunosuppressed or on steroids as well would have additional benefit. Not really any evidence in trauma. Not really a huge amount of evidence in aspiration or spinal injuries. There have been some papers recently talking about whether we should give mineralocorticoids to patients with septic shock, as well as just glucocorticoids, or not. And again, I think the jury's still out on that one, really. Steroids and sepsis, again, there's been a lot of toing and froing with this. Studies going back to the 1980s didn't show any benefit. More recent ones have shown that lower dose steroids may be helpful. And so now if the patient has vasopressor requirements that are increasing, and say is thinking about starting a second line vasopressor, so high dose NORAD plus thinking about starting vasopressin, then steroid 50 of hydrocortisone QDS would be general practice in ICU, certainly within Leicester and I think most places now. And it shows evidence of shock reversal happening more quickly and earlier weaning from ventilation, although not really statistically significant, but tends to be common practice. Some of that was from sort of subgroup and post hoc analysis, so it was a bit tricky, but seems to have relatively limited harms and may be beneficial. Yeah, I think that just covers what I've already said, really. So evidence of harm, we know that steroids, are a condition that has significant harm associated with a drug that has significant side effects and harms. One case, I don't know whether Kaya's over at Glanfield, certainly in India, after the sort of discovery of the benefit of steroids in COVID, a lot of patients were having high dose steroids given to them, and there was a massive increase in cases of mucormycosis or black mold, invasive fungal infection from black mold, that was thought to be linked to steroid usage. And we did have a case in Leicester, although not steroid related, that was very unpleasant, that Kaya was involved with. So we know that steroids are bad for head injuries. They worsened mortality at 2 weeks and at 6 months. Like we said, pneumonia, community-acquired pneumonia, the evidence base has changed a bit on that recently, but certainly don't seem to be that useful in H1N1. May be harmful in influenza, and I think Aspergillus, and some of the other flus. Certainly in the early phase, there's still quite a lot of debate about it, really. Side effects are multitudinous, hallucinations and psychiatric problems. ICU acquired weakness is certainly worsened by steroids. Things like necrosis of the femoral head, which you sometimes forget about. We all know it worsens glucose tolerance, can cause pancreatitis, GI side effects, particularly ulceration and bleeding, which may be catastrophic, and does increase risk of things like that. So, getting there, just talking a little bit about potassium now. So really important intracellular cation, really important in electrically active tissues, including heart and muscle, skeletal muscle. Really tight control of the intracellular and extracellular portions via the Na potassium ATPase. Daily requirement is about 1 to 2 millimoles per kilo per day. Most of that comes from our diet. A lot of it is filtered out by the glomerulus and then gets reabsorbed in the tubule under the control of aldosterone. We do also lose it in things like sweat and feces as well as urine. So causes are various. Signs and symptoms, things like weakness, ileus, constipation, which is why we try and correct it in patients who've had bowel surgery to try and improve GI function. And may also see reduced tendon reflexes in severe states. And in terms of ECG changes, remember that if there's no POT, there's no T, so you lose your T waves. Causes can include things like drugs, particularly if you're on high dose insulin. That pushes your potassium into your cells, makes you hypokalemic. Things like terbutaline as well. All the things that we might try and use to treat hyperkalemia can make it low as well. Aspirin and steroids. If it's less than 3.5, you then need to try and figure out where it's going. And if you're not sure, it can be useful to measure the urinary potassium levels as well, to see whether it's a renal loss or an extra renal loss, to try and help you figure out what causes and what to do about it. That's quite a useful slide if the cause is not immediately apparent. Usually in ICU, it's because of something we've done or messed up with the patient, giving them the wrong fluids, or giving them not enough potassium replacement rather than anything complicated. But occasionally you do see more complex cases. Treatment, so try and figure out what's causing it, particularly things like high output stomas or diarrheal losses. Often it gets better as the patient does, but we should try and replace and normalise if we can. We may need to do this enterally. Sandoz-K is in short supply at the moment, and tastes revolting. I'm told that the KCL is better. It may need to be done parenterally, either via a central line or fluids, but often in TPN. Better to give enterally if we can. So a whole variety of ECG changes tend to progress through ST depression, then T-wave flattening, all the way through to U waves, which you can see in here. Hyperkalemia is the opposite, has a whole variety of causes, things like hemolysis, rhabdomyolysis, particularly useful to remember, and tumor syndrome again. Might be caused by reduced excretion or increased intake or generation. And important things to think about things like compartment syndromes, including abdominal compartment syndromes, for several reasons. One, it can worsen renal excretion, but also it may lead to tissue damage and increased potassium release. Again, some drugs that can cause it. Again, anti-TB meds seem to feature in quite a lot of these potential drug causes for metabolic problems, as does lithium. Often, again, it's iatrogenic from something we've messed up. Things like potassium-sparing diuretics, particularly, can be a common cause. Quite a useful little mnemonic to remember some causes, some medications: acidosis, cell damage, changes in aldosterone, in excessive intake, and I think licorice ingestion, particularly licorice root, can cause it, so be careful with your licorice. And again, a whole variety of ECG changes. So you lose your P waves, go through peak to T waves, and then you get a broadening of the QRS, and it can progress through to like a sinusoidal pattern through to asystole. So some lovely tau-tented T waves there, some sort of loss of conduction there, and then some sinusoidal waves there as well. So treatment, again, try and find the cause. Calcium gluconate can help stabilise the cardiac membrane until such time as you can remove the potassium from the body. Remembering that if you have calcium gluconate, it's not as potent as calcium chloride, you need to give twice as much. Salbutamol can help. Insulin helps push the potassium back into the cells, so you can use a combination of insulin, but remembering to replace the dextrose so you don't render your patient hypoglycemic. But all of those things really just sort of move the potassium into the cells to buy time, whilst you try and figure out how you're going to get it out properly. And that might involve renal replacement therapy, or possibly calcium resonium, or other ion exchange resins. I've forgotten the name of the one that we're using at the moment. Is it called Leukema? Leukema is the one the trust is using, so that can be very useful. I think the policy now is that ED can give that as well, which is quite useful. So I think that's all I really wanted to say. It's been a quick whistle through. Did anybody have any questions? Any interesting cases? Anybody got any stories to tell? I think the vast majority of the metabolic work we see is unfortunately diabetes, isn't it? And various varieties. But occasionally you do get something a little bit more interesting. So keep your eyes
I had
peeled.
one on Sunday night, Jenny.
Oh, did you?
It was DKA, and the medics had treated his ketosis successfully, but according to the DKA protocol. So he had a sodium of 122 and a pH of 7.1.
What was his chloride?
Exactly. Chloride of 122, and a potassium of 1.6.
Ooh.
Which is quite impressively low, and he was struggling to lift his arms off the bed.
Mm-hmm. Yes.
And what I didn't know was they gave him, I suggested some Sandoz-K because he was otherwise better. And they gave him Slow-K, which I didn't even know existed, but I was like, that's not going to fix anything until tomorrow.
No. I think as well, like another situation where you might see quite profound respiratory embarrassment is like if you give high dose magnesium. Sometimes that can cause
in obstetrics maybe.
Obstetrics,
for the preeclamptic ones,
yeah. Yep.
That's why they do deep tendon reflexes all the time, isn't it?
It is.
I'm just going to share the feedback thing.
Yeah. So a quick summary slide.
Oh yeah, do that first. Right.
Some useful references. Personally, I really like Medicine at a Glance. I think it's a really good textbook. It's well written by Patrick Davey down in Northampton, and very nice. But yeah, that's it. Cool. That's it all for me. Thank you.
Cool. Thank you very much for that.
That's okay.
If anybody has any questions, please shout out, but give me a moment. I'm trying to do it on my iPad rather, which is less clicky than can't see it for looking.
My name's Stephen. I'm one of the CT3s. I've kind of been around the region a bit, been here and there, but now back in Leicester. So I had a paper just looking at prognostic differences in sepsis caused by the gram-negative or gram-positive bacteria. It was a systematic review that was done fairly recently in 2023. So it came from the Critical Care Journal, fairly recent, November 2023. So it's about, what we're on, 4 months old now. It came out of Shanghai in China, but does have fairly international papers used in it as well. It was a systematic review and meta-analysis. They basically had one simple aim of the paper, which was clarifying the prognostic difference between sepsis caused by gram-positive and gram-negative and gram-positive bacteria. So they did a literature review, looking at PubMed and a few other bits. They only included English and Chinese studies over the last 20 years, basically from 2003 to 2023. It was 2 researchers that went through and extracted a load of data. The primary outcome they had was survival, notably just at 28 days. And then they had some secondary outcomes that they were looking at as well. So mainly inflammatory factors, that's like CRPs, interleukin-6, a few other bits as well. And they're looking at Apache 2 scores, SOFA scores, coagulation function, and how long they actually stayed. So there's ICU length of stay and length of hospital stay as well. They went through and found nearly 7,000 articles. Eventually, they whittled it down to about 45, and then they categorized them into high, medium, and low quality. Basically, it was just high and medium quality ones that they had, no low quality, and then 16 were excluded on language as well, because it was just English and Chinese they were looking for. So basically, the primary outcome, they found 20 studies that looked at that, and overall there was no significant difference between people who had gram-positive and gram-negative sepsis. There were They basically did some meta-regression analysis looking for confounding factors. They couldn't really find anything on that one. However, one of the issues is that I think people were defining sepsis a little bit differently. This is one of the things that popped up in their subgroup analysis. Their definition might actually account for some of the differences they saw, which will kind of be a common theme throughout the rest of this as well. So there's no clear consensus on the definitions used, although the paper doesn't actually describe, unless it's hidden away in one of their additional files that aren't in the paper itself. It doesn't really clarify what definitions were used. So running through the secondary outcomes anyway, they looked at the severity of sepsis. They found 11 studies that were doing this. They basically found that the gram-negative group generally had more severe sepsis than the gram-positive group. So that's with a p-value of 0.02. Again, the definition of sepsis did impact things here as well. So it's interesting to note that although the severity was higher in the gram-negative group, the actual survival that we just saw on the other page was no difference. Apache 2 scores with 10 studies. They found no significant difference on that one. Again, small sample sizes and definition of sepsis was an issue. SOFA scores, no difference. So no difference when they looked at all of the papers, which was only 5 they had on this one. When they sort of went through and excluded one study from that group, which was 20 years ago, they found that it did have a significant change, and they found the SOFA score was higher in the gram-negative group. So there's the one paper from 20 years ago, which was skewing things quite a bit then. They looked at length of stay. 4 studies looked at the ICU stay, 4 studies looked at the hospital stay, and again, no significant difference between the two. 12 studies looked at white cells, again, no significant difference. Inflammatory markers, so CRP, PCT, tumor necrosis factor alpha, and interleukin 6. Basically, most of them were higher in the gram-negative group, again, fitting with the more severe sepsis. So worse inflammatory markers, more severe sepsis, but still same survival and length of stay. Coagulation was mainly just a couple of studies, and again, no significant difference in D-dimer, APTT, TT, INR, or platelet count. So their conclusions basically that gram-negative sepsis had higher inflammatory markers and greater disease severity than gram-positive. But despite that, there was no difference in survival, length of ICU stay, length of hospital stay, Apache scores, or coagulation function. As I said, with the SOFA score, there was a slight difference when they excluded one study. And then the little catch-all at the end of just saying this needs to be studied further. They did acknowledge they had some limitations in their study, mainly that they were only looking at English and Chinese papers. The definition of sepsis introduced a few confounding factors. They didn't look at all age groups. It was only studies that had adults in them. If it was only infant studies, they took them out, and they didn't look at any polymicrobial infections. They just ignored that. It did note in the paper that some of the studies did have information from more than 28-day survival, but these were just ignored. They only looked at 28 days, so there could be some more information longer term or shorter term. It's difficult to say on them. So running through the CASP, I don't know if anyone's familiar with this. It's one of these critical appraisal tools, which is quite useful. You can literally just Google it, and it comes up with these. They have different forms for different study types. So this is running through the systematic review one. It basically just asks these questions and says, does it review a clearly focused question? Yes, it does. They were looking at any prognostic factors. It's a fairly broad question, but it achieves that aim, I guess, in a way. Did they look at the right type of papers? It appears they did. It was a large systematic review. They looked at prospective and retrospective observational studies when we actually go into the details. A lot of these are done in quite big places, so it looks like they found vast majority of things. They did exclude the other languages, though, is question number 3. It was literally English, Chinese, so everything else was excluded. So there were 16 papers there that they didn't look at, just because of language. So it probably covers most things. Most things will be in English. They did get a lot of Chinese ones in there because that's where they were based. I think most of the studies were European, and then most of the studies were Chinese, a lot European, but there was none from the UK in there. So did they do enough to assess the quality of the included studies? It sounds like they did. From what I can see, they did score them into high, medium, and low quality, and they've just found they had high and medium. They did detail their scoring systems that they used to do that, so it seems fairly robust. If the results of the review have been combined, was it reasonable to do so? Yes. They published all of the individual study results and their charts that were actually in the paper itself, and then they combined them all to give the overall outcome, which is the ones that we've discussed. They did discuss the reasons for the variation in the discussion at the end, and they came up with some fairly sensible points, mainly, again, this definition of sepsis that kept coming up. So section B is looking at results. So the overall results of the review are what we've just been through, summarising the paper. Basically, no significant difference in survival, but there is a difference in severity and inflammatory markers. So looking at how precise the results are, looking at survival seems reasonably precise. We have a confidence interval that's given us something what we want anyway. When they were looking at severity, you have quite broad confidence intervals there, ranging from basically 1 up to nearly 3. So not that precise at all, but it gives us a general idea. So section C of the tool is this applicable locally? So can the results be applied to the local population? Say generally yes. So it was at least European studies, some from the USA and Japan, and 30 from China, and no UK studies were included. However, they were all ICU patients. So although it's not based on a Anglo-Saxon population, it is still probably fairly applicable. I don't think sepsis changes that much around the world. So were all the important outcomes considered? This is where I've picked up on. They only really looked at the 28-day mortality. They just completely ignored papers looking at longer term than that. However, answering their question of prognostic factors probably did a reasonable job at looking at things. Survival is the main thing. Hospital stays a useful indicator. And then they did look at a few of the other markers that we routinely look for as well. So I'd say yes on that one. I think the last question was, are the benefits worth the harm and costs? Well, it was an observational study more than anything, so we weren't really looking, we weren't making an intervention, so there's not really any harms or costs to it, I think. Right, that was a very quick run through anyway. I thought I had 10 minutes, so I'll try to make it fairly speedy. The paper is there, and all the links to it, so if anybody had any questions about it or anything they want to say.
Is anything that you read going to change what you do, or change how you manage people, do you think?
Probably not. I suppose I don't know how many massive differences in treatment between gram-positive and gram-negative sepsis. So, looking at that, would it change much? Probably not a vast amount.
I don't think it changes much in the acute phase, to be honest.
No.
You just treat them as a septic patient, and it might make a difference to longer term outcome and complications as to what the original source was, but I don't think it makes a huge amount of difference. I just thought it would be interesting to find out what this said, basically, but yeah, not much.
Not much difference between the two.
Not much difference.
One
really.
looks worse, but they survive the same.
Yeah, pretty much. Never mind. I'll put the feedback slide up again so that you can get some and Dr. Briggs can get some, which I'm sure will be appreciated. And then you guys will get certificates for attending. So if you please do some, that would be great. Thank you very much. Have a lovely weekend.